Hello, my name is Steve Pratt. I'm a practicing anesthesiologist and a consultant to the Betsy Lehman Center on our project for peer support. If you are watching this video, it means you are one of the peer supporters for your institution. I want to say thank you and congratulations, because this is an incredibly important role, as you'll see over the next 20 minutes or so. We work in an amazingly stressful emotional environment. We often cause, or at least have to bear witness to, profound human suffering. As much as we try to care for people, we often see things that go badly. When these things do go badly, we're expected to keep working because we're essential workers. And we work in systems that are imperfect and actually often either fail to prevent our errors or all too often actually encourage those errors. And about half of us experience one of these traumatic, emotionally difficult events each year. However, we've also found that it's very stressful for our folks just to go to work, even when things go as well as they can go. We get harmed there. COVID has made this all too clear. When we get redeployed, we worry about whether we're going to get sick while we're at work. We're dealing with shortages on a daily basis. We have understaffing, and COVID has made that worse. And we're almost always under some sort of production pressure. And then we're people too. We have to go to work while we're emotionally harmed. We may be dealing with difficulty with our kids, or our pet has died, or we're in the middle of a divorce or other big personal issue, and we have to figure out how to put those emotions aside. And so I want to talk a little bit about all three of these types of emotional difficulties, but particularly the one related to adverse events and error. When we look at the peer support programs, and we'll talk more about what that really means, there are a lot of reasons that people come and want to talk to each other. These are all written here. As you can see, very few of them actually have to do with adverse event or medical error, and much of it has to do with the work environments. The purple one on the left and the gold on the right talk about work-related issues. These are data taken from some of our hospitals here in Massachusetts. And often people just want to talk about the high production pressure, the high volume, the difficult interactions they have with patients. They just need a place to unload. Other reasons may be personal problems. Maybe a coworker death, a divorce, a death in the family, those kind of difficult emotional issues that can impact all of us at work. But we're really going to spend some time talking about that part that is particular to healthcare providers, those issues related to adverse events, to medical error that are so poignant to our lives, that where we actually may be causing, or at least having to watch those really difficult events. We have a lot of data on this, and a lot of data as to how peer support can be particularly helpful in these particular areas. So what do people feel after they've been involved in one of these particularly difficult events, difficult cases? Well, there's a word cloud, and I'm sure you've seen these in other areas. As you can see, being afraid, being sad, being ashamed, feeling alone, these are some of the very big and common feelings that people have. But the reality is, almost any feeling is normal. These are difficult times, and almost anything we feel can be normal and frankly common. One of the first papers on this was done by Sue Scott out of the University of Missouri, and this is actually an important paper for you all to know something about. I often give this paper to my colleagues when they've been in a tough case. Sue and her colleagues interviewed about 30 staff who had been involved in some sort of adverse event or medical error. And they found some very consistent and powerful findings. First, there was a huge gamut of both emotional and physical symptoms. No, you don't need to memorize these, but what's important to know is there are a lot of different, both physical and psychological symptoms that people tend to have. This has been reiterated or found in other areas as well. Dr. Gazzone interviewed anesthesiologists and found a similar set of feelings. The important part of Gazzone's work was that 5% of the anesthesiologists admitted to using alcohol or drugs as part of their management of these big feelings. This is likely underrepresented, and it's something that we all have to be on the lookout for. As I said, we found this across many different types of clinicians. This is some of the data taken from nurses, very similar types of symptoms, very similar types of emotional responses. And our own work here at the Betsy Lehman Center, in looking at some of the staff in Massachusetts, has found that almost all types of healthcare workers, clinical and non-clinical, have had a high rate of these emotionally impactful events within just the last year. Administrative staff, 1 in 4, on up to about half of the nurses and physicians. We now have a broad array of data across many different specialists demonstrating these kinds of emotional events occurring for all of us. One of the other things we've learned is that the emotional recovery from these events tends to take a pretty consistent arc. Much like the stages of grief that we go through with a death in the family, there's a series of stages that we go through with recovery from these emotionally difficult events. It starts with sort of chaotic response to the event, thinking, oh my God, what did I do? How do I fix this? We then have these intrusive thoughts that may go on for days, reliving the event, trying to think what we might have done differently. We then try to restore some sort of personal and professional integrity, get back to work in some way. Then stage 4 is actually called enduring the Inquisition. That is, we go through the various quality review processes and have to live through that. Finally, we may get some sort of emotional first aid, start to feel better, and then get onto our final stage. And for some people, folks actually get better. They say, hey, how do I become a better clinician? But all too many are only struggling along, sort of just surviving, not really thriving. And a few either drop out of healthcare completely, or actually there have been cases of suicide after these sorts of events. Well, why should we care about all of this? What's the big deal? As I've already said, we're losing staff because of this. When we look at the reasons that people left or where they went after a major adverse event, this is more of Sue Scott's work. Many left clinical medicine and went to a non-clinical, or went to a different department that may be less stressful. Some left healthcare and went into consulting or patient safety and quality, all important work, but we need these folks in the clinical environment. The other reason this is important, and I've mentioned this already, is that there's a clear association between these events and worries about suicide. This is a work by Shanafelt looking specifically at surgeons, and you can see that the third one down, perceived medical error in previous 3 months, was a powerful predictor of suicidal ideation. And the surgeons admitted to this, which is powerful enough, but more importantly, the rate of suicidal ideation was more than double the expected. And largely this was due to these adverse events and error. But perhaps the biggest reason that we should care about this is the impact that these events can have on quality. I want you to imagine getting onto an airplane, taking a look into the cockpit the day after Sully had saved the folks on the Hudson. And you realize that Sully Sullenberger is your pilot again. I don't think any of us would want to fly with him after he'd been through that kind of dramatically traumatic event. And yet we in healthcare do this routinely. This is some of Gazzone's work, asking clinicians, do you think your care your subsequent care after a major adverse event was impacted? And many of them said it was. And for about 1 in 6, it was impacted for more than a week. And about a third of those said that they thought their care was severely compromised. This is, again, some of Shanafelt's work showing that those with high EE, that's emotional exhaustion, were much more likely to be involved in a medical error, suggesting that when we're emotionally stressed, we're more likely to make mistakes. This is a study that's now more than 20 years old, where they followed obstetricians after either a baby that had very low APGARs or a baby that had been delivered with shoulder dystocia and got stuck as it was trying to be delivered. And they found there was a dramatic increase in the cesarean delivery rate in the subsequent deliveries by these folks. That doesn't sound necessarily so surprising, but what was really interesting is those that had babies with low APGARs, the reasons for their a higher C-section rate was almost entirely because the fetal heart rate tracing didn't look good. And those that had severe shoulder dystocia, the reasons for the increase in the C-section rate was almost entirely because they said the baby wasn't fitting and the labor was going too slowly. It is clear that these obstetricians changed their practice because of these events, and perhaps changed them in ways that was harmful to their subsequent women. Perhaps women got C-sections that didn't need to. So this is what we're trying to prevent as we look at folks who have been involved in these adverse events. They have an event on the left-hand circle here. They get emotionally harmed, and then they get distracted, or they change their care. They're somehow focused on that event. And in doing so, they end up with another adverse event, and around we go. Or they get involved in an event, they take time off because they've been stressed, or maybe they leave completely. This creates production pressure among the staff who are still there, who are now at an increased risk of having their own adverse event, having their own emotional impact, and then potentially leaving themselves. Well, so what do we do? Now what? We've got a bunch of emotionally impacted clinicians. We know that it's harmful to the care they provide and to their own well-being. What do we do? Well, as it turns out, talking with each other, talking to peers is what folks want to do. This is some of the original work out of Sue Scott's work in Missouri, and just interviewed folks and said, after one of these events, where did you get support? And among those who did get support, mind you, many did not, but among those who did, the most common was from a colleague or peer, or a manager or supervisor. So again, somebody who was directly in healthcare. Less commonly, it was from significant others, family members, friends. Similar work out of the Brigham said, hey, who do you want to talk to after an event? And you can see at the bottom, faculty, colleague, resident colleague, program directors, chief residents, faculty peer support, that folks want to talk to clinicians. Now, this was done almost exclusively among doctors, among physicians, but this has been shown across a wide range of specialties within healthcare. Again, we found similar data when we interviewed staff across the state of Massachusetts, that more than half said they wanted to talk to somebody. That was what they wanted to do to manage these events. And when they said, well, who do you want to talk to? Again, 3/4 of those folks said, we want to talk to a peer. Less commonly, partner or spouse, friends, supervisors. But clearly, speaking with a peer is what people want to do. And it makes some sense. We've walked the walk. We've been there. We know what that pain can feel like. All right, well, is there any benefit to this? Is this helpful at all? And the data suggests that it is. Again, Sue Scott's work, and this is a little bit of a busy slide, but as you can see in that first column, if you've been, quote, a second victim, been involved in one of the events and gotten support, these rows are measures of safety attitudes within a unit. So how safe do people believe their unit to be? And in that first column are the scores among folks who've been involved in a major adverse event and received support. So their safety attitude towards teamwork was a 4.14. But if you've been involved in an adverse event and did not receive support, your attitudes towards the teamwork on your unit was statistically lower. That is also true of managers promoting safety, perceptions of general safety on the unit, staffing, communication, handoffs, etc. So it appears that getting support is associated with improved safety attitudes. We found this as well. This was our overall grades of safety among clinicians and other staff members in Massachusetts. The overall grade of safety, the higher the number, the better here. And those orange middle columns, middle rows there, are all folks who have had an event and spoke to a peer and tended to have higher scores than that top golden row within each one of these that says they had an event and did not speak to a peer. So overall safety grades, higher. Feeling afraid to ask questions. This is a reverse question where a higher score means you were not afraid to ask questions. So if you had an event and spoke to a peer, you were less afraid to ask questions than if you had an event and did not speak to a peer. Again, where you feel safe to question authority, higher if you had an event and spoken to a peer. And how comfortable did you feel speaking up? We similarly found that talking to peers was associated with recovery from these events. Again, a slightly busy slide, but the orange here is did not speak to a peer, and the blue is they did. And this was what percentage of people had these symptoms that never went away after the event. So again, at the top, the folks that had described anxiety after one of these events, for 30% of them that did not speak to a peer, it never went away, but that decreased to 23% when they did. Similarly, frustration with work was 31% if you didn't speak to, and dropped in half to 16 if you did. So it appears that speaking to peers actually helps us to recover emotionally. Finally, the folks at Johns Hopkins did a financial analysis, and they looked at how impactful is peer support with regards to turnover, lost days, people taking time off of work. And they actually interviewed staff who'd been involved in adverse events, and whether or not they'd used their RISE program. That's the name of their peer support program. And this was a mathematical model. They didn't actually measure turnover and loss of staff, but in their modeling, they found that they saved on the order of $22,000 for each peer interaction that they provided. That the number of days lost or the number of people who left the work completely was so impactful that they saved on the order of $22,000 for each time they did peer support. So in review, we work in an emotionally difficult environment with multiple reasons for emotional harm. In particular, the impact of error and adverse events are unique to the healthcare system. There are very few other places where people can cause harm to the folks with whom they are working. The emotional impact of these events can lead to both our own individual harm, loss of staff, potentially suicidality, but ongoing additional subsequent harm in our next patients because of the emotional impacts that the initial events had. And it appears pretty clear that emotional support from peers is both desired by our staff and appears to be helpful, appears to help people to recover and to become their better selves in the subsequent care. And so with that, I'll say thank you. Thanks again for being part of this important work, and good luck.